In fatty infiltration, there will be increased echogenicity of the liver due to increased attenuations of sound beam, giving typical appearance of the bright liver. So liver will appear brighter in fatty infiltration. So fat infiltration is usually reversible, and this is acquired disorder of the metabolism resulting in triglyceride accumulation within the hepatocyte. Diagram A, B and C. Here you can see the liver ecotexture is more than that of the kidney. This entire structure is liver, and here you can see this is kidney. If you compare the echogenicity of the liver to that of the kidney, then you can see the liver ecotexture is quite higher in all of these diagrams. However, here you can visualize diaphragm clearly, and you can visualize this blood vessels. Similarly, on diagram D, you cannot visualize blood vessels. Here you can see there is hypoechoic area in between the echogenic liver. So this is the focal fat sparing area, and focal fat sparing area is a common pathology that you can encounter in fatty liver. Certain part of the liver lacks normal fat infiltration and appear as a hypoechoic area. So here are various diagrams showing fatty infiltration of the liver. In all of this diagram, if you compare the echogenicity of the liver to that of the kidney, that you can see the echogenicity of the liver is quite higher than that of the kidney. Similarly, in diagram H, you can see there is focal fat sparing area in caudate lobe. In diagram I, you can see fat sparing area in entire left liver lobe. Sometimes focal fat sparing area can be confused with liver mass. Focal fat sparing area is more likely to present at liver segment 4, and it does not take flow on color Doppler imaging. Category of the fatty liver. So fatty liver can be categorized into mild, moderate and severe. So in mild fatty liver, liver ecotexture will be more than that of the kidney. However, the diaphragm and the echogenic rim around the portal vein will be clearly visible. Here you can see this entire structure is liver, and this echogenic rim represents diaphragm. So diaphragm is clearly visible in this diagram. Similarly, this echogenic rim around the portal vein, you can see, if you can visualize the echogenic rim around the portal vein, and if you can see the diaphragm, this is mild fatty liver. However, if there is the loss of the echogenic rim around the portal vein, but the diaphragm is still visible, then this is moderate fatty liver. And if there is the loss of the echogenic rim around the portal vein, as well as if we cannot visualize diaphragm, then this is severe fatty liver. So grade 1, diffusely increase in liver echogenicity, normal visualization of the diaphragm and intrahepatic vessel border. In grade 2, diffuse increase in liver echogenicity. In grade 2, diffuse increase in liver echogenicity, but there will be poor visualization of the periportal borders. Severe fatty liver, there will be diffusely increased liver echogenicity with poor visualization of the diaphragm. Another important clinical condition is acute hepatitis. Diagnosis of the acute hepatitis is clinical and biochemical because in majority of the patient, imaging can be normal. Ultrasonography findings in acute hepatitis are enlarged hypoechoic liver. If we compare the echogenicity of the liver to that of the kidney, then the liver will appear hypoechoic. And in acute hepatitis, usually liver will be enlarged. Another important finding is periportal edema. And if the patient has hypoalbuminemia, gallbladder wall may be thickened. Sometimes in acute hepatitis, spleen can also get enlarged. So in acute hepatitis, Doppler is usually normal. Here you can see liver is hypoechoic and the gallbladder wall is thickened and edematous. So chronic hepatitis, most cases are sonographically normal in chronic hepatitis. However, there will be diffusely increased echogenicity and altered ecotexture. Another important condition is focal fatty infiltration. Here you can see there is hyperechoic area in between the normal appearing liver parenchyma. So this is focal fatty infiltration. A characteristic location is medial segment of the left liver lobe, usually segment 4. The distribution is same as that seen in the focal fat sparing, as we have already discussed. In focal fatty sparing, segment 4 is involved. in but in focal fat similar to focal fat infiltration. Hepatic adenoma. So hepatic adenoma is a benign, generally hormone-induced liver tumor. They are usually solitary. Risks of the malignant transformation is around 4 to 8%, but the hepatic adenoma can undergo hemorrhage. Around 30% of the cases, hepatic adenoma can undergo hemorrhage. Obesity and the OCP use actually increase the risks of hepatic adenoma. Hepatic adenoma is quite common in right lobe of the liver at subcapsular location. These are well demarcated, round, hyper or hypoechoic masses, and occasional calcification and hemorrhage can be seen. Larger size and male sex, higher risks of the malignant transformation. So here in this diagram, well demarcated, round, hyperechoic structure is hepatic adenoma. Focal nodular hyperplasia is second most common cause of the benign liver lesion after hemangioma. Liver mass that is difficult to differentiate in echogenicity from the adjacent liver parenchyma. Here you can see there is ill-defined isoechoic or somewhat hyperechoic area inside the normal appearing liver parenchyma. So this is focal nodular hyperplasia. Focal nodular hyperplasia usually have central fibrosis scar that may be hypoechoic or hyperechoic and linear. Nodular hyperplasia is actually a regenerative mass, common in female. There is no association with OCP like that of hepatic adenoma, and the complications are quite less common in focal nodular hyperplasia. These do not have portal venous supply.